Pop quiz. Can you name something that you've done and practiced at every MCI training that you've ever been to, but doesn't seem to ever really happen on any actual MCI scene? I'll tell you what it is on this One for the Road. Have you ever done an MCI training where you walked into the room and you told everyone who could walk or move to, stand up and move over to this area, and then you were allowed to triage everybody else and put a tag on them, like a triage tag, and then some other folks came and they moved them to a treatment area? Sure you have. Most all of us have at some point. But research reviewing real MCI scenes tell a different story. It just about never actually works that way. And if triage on your actual MCI scene doesn't go as planned, I want you to know a few things about it. First thing I want you to know is that we've never actually validated that any of our triage methods actually work. It's difficult to study them because they're rarely used. We have to wait for an MCI scene, and those scenes often we don't actually use those triage methods. So whether you're using start triage or salt triage, we've never actually done the research to say that they work any better than just kind of guessing who's more critical than somebody else. Triage tags and triage methods are typically, they're ill-suited for an actual MCI environment. One, we need to bring them along with us. At the moment we realize we're in an MCI, if they're not in our hand, we're not going to be able to use them. And oftentimes that's the case. Also, walking wounded are often helping other people. I think the Boston Marathon was a great example. And we've all seen those images of people on the sidewalk being helped by the people that were around them. Do we really want to ask all of those people to get up and walk away when they're possibly helping to treat critical wounds at the place that they're at? Those that can move often do move, even sometimes when they have significant injuries. And a good example of that was the Aurora Theater shooting, where people with significant gunshot wounds were found that critical wounds often get addressed in place, and non-critical patients are often triaged after they reach casualty collection points. And the Harvest Festival in Las Vegas was a good example of that, where very few people actually were triaged at the place of their injury. It was the casualty collection point where triage and treatment took place. So what do we do? First, I want you to please understand that chaos will likely reign on any mass casualty scene for a little bit longer than you're comfortable with. And we train this wrong. I think we train with this idea that instituting something like start triage is going to instantly take a very chaotic scene and bring it under control. And actually, it's probably going to stay chaotic for the first 10, 15, 20 minutes. And that's okay. Don't feel like you did something wrong because that there's a lot of chaos and disorder on a mass casualty scene. That is just the nature of those scenes. Also, don't feel bad if the triage method that you learned doesn't fit your scene. If your start triage or your salt triage doesn't seem to fit the situation that you're in, it is okay to back off and go with something more like what we would call a gestalt feeling of, I think this patient's more critical than this patient, so I'm going to take care of them first. And for all we know, that may be every bit as accurate as those more formal triage devices. Also, don't abandon your training. I'm not trying to say that we should throw out these tools or that we shouldn't train on them. This isn't about that at all. If those tools work, please use them. In fact, on smaller MCIs, scenes with 5, 7, 9 patients, on those scenes, actually, those triage methods work quite well to try to decide who should we treat first, who should we treat second. It's those larger scenes where they don't seem to fit perfectly. Understand that if casualty collection points are where that triage and treatment has to happen, that's totally okay as well. And when in doubt, know that controlling bleeding, managing the patient's airway, and moving the patient towards the hospital are always foundational principles that you can fall back on. I hope that you are never faced with the triage of a large-scale mass casualty incident. And if you are, I'm hopeful that your training and your experience are up to the task as much as they can be, and that the best of you shows up to meet that challenge. Know that your training is only going to take you so far. You'll need to take what you know and adapt it to a completely unique circumstance. Hey, I appreciate you watching. Thank you. I'm Steve Whitehead, and that is One for the Road.